Hello everybody, welcome back to part 2 of approach to antibiotic uses. In second part we will be talking about a specific approach to specific infection. Let's dive into it. Is 7-day course of antibiotic adequate for bacteremia? Very important question. And there was a randomized controlled trial published in NEJM 2025. This is one of the trials that is going to change the way we practice medicine. So they were looking at antibiotic treatment for 7 days versus 14 days in a patient with bacteremia. As you can see, 3,608 patients were enrolled. Out of that, half were in 7-day group and half of them were in 14 days group. And then I would like you guys to look into this exclusion criteria, which included severe immunosuppression, somebody with a prostatic valve or vascular graft, or somebody with infection, which is supposed to require longer antibiotic therapy, and in a specific infections. So it included a pretty good, spectrum of bacteria, as you can see here, and also included different source of bacteria. So it was a good study, as you can see here. And so what they found was there was no difference in primary outcome, which was 90-day mortality, when they compared 7 days versus 14 days. It was non-inferiority trial. So as you can see, the confidence interval, includes zero. So it was not significant. So, so the conclusion was among hospitalized patients with bloodstream infection, antibiotic treatment for 7 days was non-inferior to treatment for 14 days. So talking about 7 days therapy, very recently published IDSA guideline for urinary tract infection also includes treatment for 7 days, and then the treatment duration was recommended based upon 3 randomized controlled trial published in 19, 20, and 22. And then the level of evidence they quoted was low quality evidence. But remember, when they published that IDSA guideline for urinary tract infection, that balanced trial result was not out. So if it was out, they would have easily said that there was high quality evidence to suggest 7 days course is not inferior. So does this mean we can treat all bacteremia patients with just 7 days of antibiotic therapy? Of course not. So as we know, those immunosuppression people with organ transplant or stem cell transplant, those were the exclusion criteria, and also those graft people that we are talking about, and something that requires longer duration of therapy, on-drain abscess or septic arthritis, where you tend to need longer duration of therapy, and also pathogen which requires longer duration of therapy, like we talked about, and also mycobacterium, nocardia, actinomyces. So those kind of organism, they typically require longer duration of therapy. And another important point I'd like to look at these two curve. The skier is going to reach faster on the left side. It's going to take longer on the right side. So what does that mean? So when you are treating, infection, if infection course is downhill, like on the left side, you are going to treat with a shorter course of therapy. Versus if somebody is not recovering that well, taking some time, they probably need a longer duration of therapy. And then in the same trial, if you look at the difference between gram positive and gram negative, the gram negative, but 7 days therapy was non-inferior, and it was neutral side on polymicrobial and gram positive. So my gram positive infection tends to require a little bit longer duration of therapy. So let's start with skin or soft tissue infections, which are classified based upon presence of pus. Uh, infection with pus are called purulent cellulitis. Infection without pus are called non-purulent cellulitis, and they are also classified based upon severity. They are classified as mild, moderate, or severe disease. Somebody with systemic signs, those are considered moderate disease, and somebody who have sepsis, who have failed treatment, or somebody who is immunocompromised, those folks are considered to have a severe disease. So let's talk a little bit about staph and streptococcal infections. Staph secretes coagulase. What coagulase does, it changes fibrinogen into fibrin, and what fibrin does, it walls up the area, and the bacteria does intense damage in that localized area, resulting in necrosis of the tissue, and it results in the formation of the pus. So Staph aureus infection, classically they are pus forming. On the other hand, streptococcal infection are spreading in nature. Streptococcus, secretes streptokinase and hyaluronidase, which actually dissolves those fibrin strand and results in spreading type of infection. So that is a basic difference between streptococcal and staphylococcal infection. So when you look into this slide over here, treatment of purulent cellulitis primarily revolves around draining that pus. Whenever there is a pus in the body, that needs to come out. If it is in the accessible side of the body, you do incision and drainage, and if it is in the body cavities, you have to aspirate or you have to drain that pus. If you don't do that, basically, even if you give antibiotics, that antibiotic is not going to work in that pus. So that is the first principle. And then, as you can see here, the treatment of purulent cellulitis in the mild disease, incision and drainage is sufficient. We'll be talking about that in the future slide. And then in moderate disease, empiric treatment, trimethoprim sulfa, doxy, and then definitive treatment consists of dicloxacillin and cephalexin. If your patient is obese and you have concern about adequate tissue level not being obtained, you can consider IV in those folks. And then what are the MRSA risk factors? So MRSA risk factors, somebody with a nasal colonization, or somebody who had a MRSA infection in the past, or somebody who has been to the hospital in the last 90 days, or somebody who has been treated with the recent antibiotics. So those are the folks who are at risk of MRSA infection. And as you can see here, severe disease, again, you do IND, empiric treatment consists of coverage for MRSA, and then definitive treatment is based upon culture and sensitivity report. And then non-purulent cellulitis, there is no pus. So basically, the primary treatment is going to be antibiotics. And remember, most of the streptococcus are still sensitive to penicillin, so you'd like to choose, penicillin group whenever you can. As you can see, anything beyond moderate non-purulent, MSSA coverage is given. Somebody with a severe disease, including penetrating trauma or history of MRSA infection elsewhere, or nasal MRSA or IV drug uses, those people you may want to give MRSA coverage. And as you can see there, surgery is done in the severe disease for culture and sensitivity, because you want to know what antibiotic is going to work. And then typically those severe cellulitis, a patient we treat with the vancomycin and Johnson. So let's go to the next slide. Remember, not all rivers are sepsis. Misdiagnosis of non-infectious conditions like venous stasis and dermatitis, trauma-related inflammation, DVT, or thrombophlebitis is pretty common. So whenever you have a patient, the bilateral leg redness, most likely it's not a cellulitis. We already talked about difference between purulent and non-purulent cellulitis. Purulent cellulitis, presence of pus,
typically caused by staph, and then not always you need antibiotics. On the other hand, non-purulent cellulitis, which is typically caused by streptococcus, and most of the time you treat with antibiotics. Remember, most streptococcus are still sensitive to penicillin, and then up to 10 to 20% of these streptococcus are now resistant to clindamycin. So remember that when you are choosing antibiotics. Do you need gram-negative coverage? Answer is no. Gram-negative organisms, they don't cause cellulitis most of the time if your host is normal host. Even in the diabetics, gram-negative coverage is not always needed. What is the indication of gram-negative coverage in cellulitis? If your patient is immunocompromised patient, if there is a concern about necrotizing infection, if it is an infected diabetic ulcer, especially if your patient has been obsessive about washing their feet, and then remember, Pseudomonas loves the moisture. So those diabetic ulcers, especially if your patient has been obsessive, about washing those diabetic ulcers several times a day, those ulcers might be colonized with the Pseudomonas. So remember that. Perirectal infections, bites, aquatic injury, or severe surgical site infection involving groin or abdominal wall. So these are the indication for gram-negative coverage. And then how long to treat for? 5 to 7 days course should work for the most. And then by day 3, the patient should be improving, and then most can be changed to oral by day 3, because we should have some information by day 3. Next slide. Rapidly progressive cellulitis you see with group A streptococcus classical patient, patient with a lymphatic disease, either status post cabbage or status post mastectomy, pasteurella multisida with animal bites, Clostridium perfringens with a wart trauma, Vibrio vulnificus. Classical patient is cirrhotics, playing golf in the coastal area, and then having exposure to seawater, and then getting Vibrio vulnificus from the seawater. And then since they are cirrhotic, they don't have complement, they tend to have fulminant disease with the Vibrio vulnificus. Necrotizing fasciitis is very important diagnosis that you should not be missing. Necrotizing fasciitis is a misnomer. There is no predominant necrosis of fascia. Necrosis is predominantly in the muscle. Fascia are actually relatively spared. Very important principle is these are the deep infections. So when you look at the wound, it does not look that bad. It looks dusky blue, and there might not be significant erythema there, since it is deeply situated. So if you see here in the picture, see how deep is the necrotizing fasciitis. So here, so you don't see a redness from outside. So it's very close to muscle, and then basically they might have skin necrosis or blebs. They complain of disproportionate pain. So the wound does not look bad, but they have very severe pain. And then all of a sudden, when they lose pain, that's not a good sign. Why they lose pain? That means their nerve are dead. So that's why they are not feeling anything. So, and then they have disproportionate systemic toxicity. And then when you do x-ray, you see gas. When you feel crepitus. So whenever you see these findings, you need to think about necrotizing fasciitis, because it's a medical emergency, and you have to have early surgical consult, and you have to give big guns to antibiotics to this patient, covering MRSA, covering gram-negative, and covering anaerobic. And addition of clindamycin to these people has been shown to improve the outcome. Clindamycin is a protein synthesis inhibitor, and clindamycin inhibits some of the proteins that actually causes this necrotizing fasciitis. And that's about necrotizing fasciitis. So let's talk about antibiotic in uncomplicated skin abscess. So classical teaching had been not giving antibiotic to skin abscesses. Then came this study published in NEJM 2016. What they did, they look at uncomplicated abscess, IND in the ED, and then they compared between Bactrim versus um, placebo for 7 days. What they found was the cure rate, as you can see here, was better with antibiotics, 92 versus 85. Then the need for a repeat IND was more with the placebo. So there was a benefit in the patient. The benefit was not limited to patient themselves. It was also seen in the household contacts. So up to 4% of the people who were not treated with antibiotics, they had infection in the household members. So after this study, we started treating uncomplicated abscess with short course of antibiotic. So in terms of choice, what to choose, they compared between clindamycin and Bactrim and placebo, and then they look at the outcome at 10 days, 1 month, and they also look at the adverse reaction. What they found, compared to placebo, both antibiotics were effective. And when they compared between clindamycin and trimethoprim sulfa, clindamycin had more side effect. So after this study, we started choosing more Bactrim or doxycycline rather than clindamycin when it was small skin abscesses. Remember, clindamycin has some resistance, development of resistance to streptococcus as well. So, which is really interesting finding. So that we should not be giving clindamycin to everybody. Then, do we need to treat with two antibiotics? The answer is no. There was no additional benefit with a combination of cephalexin and Bactrim compared to cephalexin alone. So we just give one antibiotics. So let's talk about bacterial meningitis. Somebody comes to the hospital with fever and alternative status. So first thing first, you stabilize the patient, you send for blood culture, and then you are going to ask your patient about these 7 factors. And is your patient 60 years or old? Is your patient immunocompromised? Does your patient have a CNS disease? Or had a seizure in last 1 week? Or papillary edema? Or focal neurological deficit, alternative status? So any of those factors are positive, then you need to get image. You need to get CT scan or MRI before lumbar puncture. If those are negative, then you can get lumbar puncture. You send for cell count, culture, and chemistry. Chemistry consists of glucose and protein, and then you continue empiric antibiotic while awaiting the culture report. And then as soon as you do lumbar puncture, you start on dexamethasone 10 milligram and you continue that Q6 hours, and typically given just before antibiotics, and then you give empiric antibiotic based upon age and the risk factor. So these are the antibiotics that you are going to choose for different kind of infections. You can see here, and then um, if your culture comes back negative for pneumococcus, then you are going to stop dexamethasone. Otherwise, you are going to continue. If it comes positive for pneumococcus, then you continue that for a total of 5 days, because only with the pneumococcus, dexamethasone has been shown to decrease cranial nerve palsies. So that's why we continue dexamethasone in that specific instance.
So let's switch our gear and let's talk about urinary tract infection. And let's start with a question. 44 female with a history of bipolar disorder with no other comorbidity admitted in psych floor with suicidal ideation. And you are consulted by psych team to evaluate for urinary tract infection. She admits to recent use of crack cocaine. Urine analysis and UDS were sent as a part of her admission lab. She denies any fever, chills, urinary frequency, or abdominal or back pain. Physical examination was normal. Labs are given in table 1, fairly normal. UD is positive for cocaine. Um, Nitrates positive, leukocyte storage 2 plus, urine culture 10 to the power 5, E. coli, pregnancy test is negative. What would you recommend to psych service? So these are the options. So the correct answer here is no treatment at this time. So as you can see, patient was asymptomatic. So her urine was positive, but when you went and asked the question to the patient was not having any symptoms. So people with asymptomatic bacteria are not treated except in the special conditions. Let's talk about asymptomatic bacteriuria. So only three subset of population that you are going to treat. Number one is pregnancy. If you don't treat in pregnancy, during pregnancy, there is progesterone which causes dilatation of all the sphincters. And there is a increased risk of ascending infection. So more risks to the mom, and then there is a risk of premature delivery, so more risks to the fetus too. So for that reason we are going to treat, and first trimester and last trimester you are going to use um, um, nitrofurantoin or cephalexin. um, Otherwise you are going to use trimethoprim sulfa for 12 weeks to 36 weeks. Then if your patient is going for a urological procedure with bleeding, so remember, invasive urologic procedure, just cystoscopy is not adequate. Just fully catheterization is not adequate. So in that invasive urologic procedure, you are going to treat with 3 days of fluoroquinolone. If your patient has a renal transplant less than 3 months back, you are going to treat with fluoroquinolone for 3 days. Everybody else, no treatment for asymptomatic bacteriuria. So remember this. Why renal transplant? If it was done less than 3 months back, it was based upon this study, which was done in Cornell um, uh, in 2013. They're looking at almost 1,200 transplant recipient for over 5 years, and what they found was almost 21% of people were having UTI in first 3 months, and then almost 68% were asymptomatic. And when they were looking at untreated UTI, the hazard ratio for rejection was 2.8 times higher, which was lower in treated population. So this study actually guided us on that uh, transplant subset for the treatment of asymptomatic bacteriuria. So let's talk about urinary tract infection. So in the past, we used to call complicated UTI as somebody with a diabetes, structural disease, abnormal physiology like vesico-ureteric reflux, foreign body, something like stones, resistant organism, and male used to be called as a complicated UTI, and everybody else is uncomplicated. IDSA changed the guideline in 2025, so they come up with a new guidelines. Many infections that were automatically labeled complicated, even if limited to the bladder in the past, now IDSA defines complication based upon the extent of infection, not just the patient characteristic. So it is complicated when it has extended beyond the bladder, including pyelonephritis, or somebody with a febrile UTI, or somebody with a bacteremia, or somebody with a catheter associated, or if there is a evidence of obstruction, those are considered complicated. While infection confined to the bladder, which is cystitis, is considered uncomplicated, even in the even in the people with the diabetes or immunosuppression. So this is a new change, and I'd like you to remember this. So as you see here, uncomplicated UTI, no fever, no signs, no chills or rigors, no flank pain, no costovertebral tenderness, and also no urinary catheter. Remember, with the urinary catheter, UTI is considered complicated. And it does not include prostatitis and also epididymitis. So remember that. On the other hand, complicated UTI, somebody with symptoms suggestive of infection, something like fever or hemodynamic instability, flank pain, costovertebral tenderness, those kind of stuff. Pyelonephritis is considered complicated. Somebody with a catheter is considered as a complicated. And obstruction or neurogenic bladder is considered complicated. And remember, this guideline do not apply to prostatitis and bronchitis. So let's talk about urinary tract infection management per IDSA guideline 2025. So they recommended using 4-step approach to choose among these antibiotics. That includes number one, assess the severity of illness, whether your patient is in shock versus without shock, versus bacteremia or without bacteremia, um, just uncomplicated or complicated. So, and then you look at the risk factor for resistance. Then you will look into patient specific considerations. And in terms of sepsis, if your patient is in shock, um, the susceptibility has to be more than 90% when you're choosing antibiotic. Versus if your patient is not in shock, the susceptibility has to be more than 80% for you to choose that antibiotic. And in terms of antibiotic, it's a classical antibiotic that we are going to choose, which is third generation or the fourth generation of cephalosporin, uh, piperacillin, tazobactam, or fluoroquinolones. Without sepsis, you are also going to choose Bactrim as one of the preferred antibiotics. So, in terms of duration of treatment, uncomplicated UTI, you are going to treat for 3 to 5 days, depending upon type of antibiotic. In pyelo, fluoro, if you use fluoro, 5 to 7 days, versus if you are using others, 7 to 10 days. Complicated UTI without bacteremia, you treat for 7 days. If gram-negative bacteremia, you are going to treat for 7 days. If your patient is improving. In terms of prostatitis, you need to treat for long duration. Remember, duration starts from the first effective antibiotic that you are going to use. In terms of nitrofurantoin and fosfomycin, very important point is that you cannot use these two antibiotics in the management of pyelonephritis. You need to attain blood level in addition to urine level to treat pyelonephritis. And unfortunately, this agent, they don't really get concentrated in the urine, in the blood. So though they are concentrated in the urine, they are not concentrated in the blood. So you cannot really use these two antibiotics to treat for pyelonephritis.
So let's talk about pneumonia. So community acquired pneumonia. So somebody presenting with the sign and symptoms of community acquired pneumonia. Um, somebody with a fever and cough. So you send chest X-ray in selected people. You do chest X-ray. You send sputum and blood cultures, and then you risk assess by by the use of port or with the use of curve 65. Either is fine. Then basically based upon that score, you determine where they belong to. Somebody with two in a curve, they need to be admitted. Somebody with three or more, they go to ICU. So this scoring system really helps you to dispose your patient, and really important when you are working in the emergency. Then for outpatient treatment, you ask yourself question, what is the risk of resistant streptococcal pneumonia infection in your patient? If answer is yes, you start levofloxacin or you combine amoxicillin with azithromycin. If answer is no, you give doxycycline or azithromycin. So what are the risk of resistant streptococcal pneumonia? So is an antibiotic in last 3 months, exposure to child in daycare, medical comorbidity, which has been listed over here. Let's go to the next slide. So, inpatient non-ICU treatment. So, how do you treat? So, if your patient is admitted non-ICU, so basically you use either levofloxacin or you combine ceftriaxone with azithromycin. Um, so rather than azithromycin, you may want to use doxycycline if your patient has a prolonged QT, in which case you cannot either use levofloxacin or you cannot use azithromycin. So in that case, what do? You combine ceftriaxone with doxycycline. So if your patient received antibiotic recently, ertapenem is the choice. And then inpatient ICU treatment and at the risk of pseudomonas. Who are the people at risk of pseudomonas? Severe structural lung disease, something like bronchiectasis, or somebody with a bad COPD who is on oxygen, or recent antibiotic users, or somebody who had a recent hospitalization. So these are the risk factor for pseudomonas. And then if there is a risk factor for pseudomonas, you may want to cover a double gram negative. So typically you give either um, piperacillin tazobactam with a levofloxacin, or you give piperacillin tazobactam azithromycin plus gentamicin, or you can also give Josin, which is piperacillin tazobactam with a levofloxacin with gentamicin. So either is fine. So the whole idea is to cover double gram negative. And out of that gram negative coverage, one has to penetrate to the lung. So piperacillin tazobactam can do that. You can substitute piperacillin tazobactam with cefepime as well. And then if there is no risk for pseudomonas, you treat like you did in the non-ICU treatment here with ceftriaxone, azithromycin, or levofloxacin. So let's talk about next case, 38-year-old male with history of opiate use disorder, admitted for fever and low back pain. And then MRI reveals IL-2 to 3 decitis and epidural fragment and with cord compression. So blood cultures are pending. So what do you want to choose for empiric antibiotics? So the cord compression, so make sure you call neurosurgery right away. And then regarding antibiotics, vancomycin and ceftriaxone. So what about cefepime? Cefepime could have been a reasonable choice as well, especially if you have a concern for pseudomonas. Especially this patient who is IV drug. If patient has IV drug abuse history, which is not clear here, cefepime would have been a reasonable choice. So vancomycin and cefepime both are started, and then you wait for the culture report, and then look here, oxacillin resistant. So what is that? That is MRSA. So turns out to be MRSA. So ceftriaxone was stopped, just continued on IV vancomycin. Then neurosurgery did operative debridement for source control, and then patient was given IV vancomycin for a total of 6 weeks per IDE recommended. And these are my references. Thanks for watching. And this is my email. If you have any questions, feel free to email me. Thank you so much.